Good afternoon. My name is Mark Thaller and I'm a clinical lecturer in Birmingham. I'm also on Twitter, so please follow me to keep updated on IH research. I will be presenting today on reproductive health in women with IAH. This talk is based on my research and it will hopefully flow through a typical journal of a reproductive aged woman with IAH. IAH is a condition of raised intracranial pressure resulting in papilledema, the swelling of the optic nerve at the back of the eye. Patients have a risk of visual loss as well as debilitating headaches. The reason for my study was because it predominantly affects reproductive aged women with obesity. Therefore, the impact of pregnancy and around pregnancy needed to be investigated further. Pregnancy can occur at any point in the IH disease course, and therefore you may be in a difficult situation of active IH during pregnancy, where there's a reduced treatment options. I plan to address the guidance on contraception, evidence about fertility in IH, the risks of some other medications, which is the iatrogenicity, as well as addressing weight gain, headache management in pregnancy, complications seen during pregnancy, as well as the recommendations for delivery. In an ideal IH scenario, pregnancies would be planned to enable disease control before conception. In particular, this would be through weight management approaches to target weight loss. This can be highlighted from our data. We can see in the patients who were known to have IH, who then became pregnant, that the swelling of the back of the eye improved, and then when this occurred, this then remained stable during pregnancy. So this provides some of the evidence for these recommendations. With regards to contraception, it's important to highlight that none are contraindicated in IH. However, often GPs are cautious with using the combined oral contraceptives in patients with migraine and aura. From our IH Life data, we found that 31% of patients have reported that IH had affected the choice of contraception, and 7% reported a pregnancy as a result of inadequate contraception. This is too high, so we're trying to disseminate the results once they are published. As for folic acid, it's recommended that all patients who are planning to start a family start this prior to, well, ideally 3 months prior to pregnancy. But it may well be that a higher dose, a more treatment dose, would be beneficial. Both acetazolamide and topiramate are used to good effect in IAH, but unfortunately their side effects often limit their use, especially at the higher doses, which are often needed. That being said, topiramate side effect of weight loss can sometimes be beneficial. There are risks involved with taking these during pregnancy, and topiramate is not recommended due to greatly increased risk of problems. However, acetazolamide is not recommended in the United Kingdom, although it is used elsewhere around the world during pregnancy. However, this is mainly based on animal studies, so sometimes an individual approach is required. To assess for the impact of an IH diagnosis on pregnancy, we carried out an England-wide study of over 17,000 IH patients and compared them to a general population without IH or polycystic ovarian syndrome, PCOS. And this latter group included almost 11 million females. One thing that we found was fertility appears to be slightly lower in females with IH, both before and after a diagnosis. And there's likely to be many causes underlying this, including patient choice, doctor's advice, as well as hormonal aspects that underlie IH. The causes for this were not able to be assessed from this study, unfortunately. Moving on to pregnancy, I will address headache management, weight management, complications during pregnancy, as well as delivery methods. The commonest type of headache in IH is migraine-like. Most people with migraine notice an improvement in their headaches during pregnancy, although this does not mean that there won't be headaches and there won't be bad spells during pregnancy. The headache management focuses on acute treatment, so that's acute painkillers, ideally at the lowest dose for the shortest time. However, this does have to be effective. It's worth noting that non-medication based treatments can be beneficial, and this includes increased hydration, reduced caffeine intake, as well as improved sleep hygiene. And there's also behavioural and medical approaches, and sometimes there can be non-invasive devices that can be used. However, these are often not available on the NHS. Obesity stigma is unfortunately widely prevalent in a society and healthcare. This image was from a talk by Professor Sally Abbott, one of the dietitians who works within the weight management service. And we know weight management is incredibly difficult, both initially, but also to maintain any weight loss. And this is probably due to the hormonal changes that occur. And often in IH, the amount of weight loss needed to settle papilledema may be quite large. However, this varies from person to person. This can be even harder during pregnancy, and although weight loss is not recommended in pregnancy due to the risks for the developing baby, it is important to note that larger amounts of weight gain may worsen IH, potentially either in pregnancy or afterwards. And unfortunately, as for eating for two, the increased requirements only go up by about 300 calories towards the end of pregnancy, much to my wife's disappointment. There are also increased risks associated during pregnancy, and this is why we would recommend the pre-pregnancy disease control where at all possible. As for complications, we looked at gestational diabetes, which is high blood sugar, which occurs in pregnancy compared to diabetes, which happens outside of pregnancy. And this is more common in the second and third trimesters. And symptoms include increased thirst, needing to go to the toilet more often, dry mouth, and tiredness. And this is often detected either through blood sugar testing, and finger prick, or potentially also through a blood test, followed by drinking a very sickly, sugary drink, and then a further blood test to assess the body's response. Treatment in the first instance would be through diet change and exercise. However, sometimes insulin is required. Another condition is preeclampsia, where the cause of this isn't fully known, but is thought to be due to problems with the placenta, and this generally occurs in the second half of pregnancy and can present with problems of headache, visual blurring, vomiting, as well as swelling of the face, hands, or feet. This is often why during pregnancy that one's urine is checked, because this is for protein, which can be a sign of kidney problems, which can occur in preeclampsia, as well as measuring blood pressure. And the treatment during pregnancy is aiming to actually lower and control the blood pressure, although the only true solution to it is delivery of the baby. However, this is aims to be delayed until baby is at term, so 37 weeks or above, where at all possible. So we looked for complications seen in IH and see that both these complications occurred in about 12% of IH patients following their diagnosis. So this was 5 times higher for preeclampsia and 2.5 times higher for gestational diabetes compared to the general population. We also compared to polycystic ovarian syndrome patients without IH, and preeclampsia was still 3 times higher. However, gestational diabetes was fairly similar. So I'm in the process of informing the teams who deal with pregnancy, because it may well be that IH patients need to be monitored more closely for these additional complications, as early management is preferred. As for the method of delivery, well, the international guidelines, the consensus guidelines, stated that there's no preferred method for delivery in IAH. That being said, you can see from our data that following a diagnosis, the elective, that's the planned surgical rate, doubled to 22%. This may be due to the mother's wishes or potentially advice from the medical teams or other complications. So we're currently discussing with the teams dealing with pregnancy, as there may need to be some further education with regards to this. It's also worth noting that in data that we're currently analysing, that the brain pressure during sort of contractions, or what we call a valsalva, which is as if you're straining to go to the toilet, increases the pressure, but this is only for a short period of time. As for long-term outcomes, these are generally good, especially for those patients with an established diagnosis of IH who subsequently become pregnant. The visual acuity, which is where you read letters from a chart, remains stable in all groups. And a visual field, when you tested to see if you can see lights of different brightness and in different allocations, was also broadly stable over time. As for the imaging, so this is through the OCT imaging, where you get the photographs of the backs of your eyes, and this helps us measure and compare over time if there's any swelling. And the good news again is that those with known IH who then became pregnant, the actual swelling stayed stable on average over the course of pregnancy. That being said, patients should still be monitored closely, but this is a good positive message. I'm sure your eye has been drawn to the red line. Now, this is a small group of patients who were diagnosed with IH in pregnancy for the first time. And you can see that the swelling worsened during pregnancy. However, this did then improve. However, this is a small group of patients. So, to summarize, that we would recommend targeting disease control of IH prior to pregnancy where at all possible. It appears that fertility may be lower in IH, however, the causes of this are likely to be quite variable. There's also an increased risk of complications during pregnancy, and therefore IH patients should be monitored closely by the obstetric team, the ones directly managing pregnancy. And as for delivery methods, so we showed that the risk of having a caesarean section was doubled following an IH diagnosis. This is rather worrying, but there may be multiple reasons underlying this. But the good news is that the long-term visual outcomes are good for pregnancies during the IH disease course. Thank you very much for listening. I'd like to thank my supervisors, mentors, and the wider team in Birmingham, as well as IH UK, who have supported my research, as well as all of the patients who have taken part with our studies. Thank you very much for listening. I'm sure you have some questions.